Neither the El Paso County Medical Society, its members, nor KCUS TV shall be responsible for the views, opinions, or facts expressed by the panelists on this television program. Please consult your doctor.
Good evening. 1 in 4 people die of heart disease in the United States, and there are many tests today that help make us be able to go to the doctor a little more easier. That's great grammar, isn't it? But it helps us be able to go to the doctor and say, hey, this is what's going on. What can I do to figure out what I have to do to make myself a little bit better? There is this X hour we have. I should just start this whole thing over. I am going to start over. Scratch all of that. So let me start over. Even though this is live, you know, those people that get to tape shows, they're pretty darn lucky. But let me start and say 1 in 4 people die in the United States of heart disease. And what I'm trying to say is that there are many more tests today than there have been even in the last 2 or 3 years. And so every time you watch the show, even though we do the show once, twice a year, there's always something new on the horizon. I've got 3 doctors with us this evening to talk about that. This is a live program. You all know that, but feel free to call us. We've got the medical students on call that are going to be answering the telephones. The number is 881-0013. This evening's program, and thank you very much, this is written by Las Palmas del Sol Healthcare. And we also want to thank the Texas Tech Paulo Foster School of Medicine, again, for the students that they provide to us to answer your phone calls. And as we do each and every month, and now for 22 years, the El Paso County Medical Society for bringing the show to you. Good evening, I'm Catherine Berg, and you're watching the El Paso Physician. Good evening. Thanks again for joining us. We are calling the show tonight, Your Heart, Your Parts. And it's interesting title, and I'm thinking to myself, we have this really great model of a heart here. I don't want to bump it because we're talking about parts. There's lots of parts to this heart. And so we're going to have some fun with that this evening because there are so many, there are 4 chambers, fine, but the ins and the outs and the blues and the purples and the reds, etc. We're going to have a lot of stuff to talk about this evening. We have 3 cardiologists with us. We have Dr., and I kind of had some fun saying this, it's Olusanya. Did I say that right?
Yes.
Cardiologist here with us this evening. We have also Dr. Francisco Cota and then Dr. Oscar Munoz, all 3 cardiologists. And when I say that, so sometimes we have doctors that have different titles. But so poor Dr. Munoz is going to be like, well, they already said what I do. So if there's anything different that the 3 of you all do from one another, if you can explain to the people at home what you do all day, every day, it kind of helps them understand your role.
All right, I'm Dr. Olusanya. I'm a non-invasive cardiologist, which means I tend to do more of testing and diagnostic studies to find out the parts of the heart that have issues and help to provide treatments. Most of my treatments are medicines, but when I need interventions, then I move over to my colleagues, Dr. Cota and Dr. Munoz.
Okay, so Dr. Munoz, that makes me think that you're a little bit more of an interventional cardiologist, is that correct?
Correct.
And if not, correct me. Dr. Cota, how about you?
Hi, I'm Francisco Cota. I'm an interventional cardiologist. Grew up here in El Paso, studied here at UTEP, and then went to Houston for 11 years and then came back here to the community that I grew up with. And like Dr. Olusanya said, whether we're interventionists or general cardiologists, we always try to start with basic cardiology and then start to evaluate the heart from there. And we do more of the interventions, kind of doing, taking care of acute heart attacks, placing stents, placing pacemakers for people with low heart rates, and also now intervening on legs for the improving circulation and wound therapy.
It's interesting you were talking about placing stents. I just today, I have mitral valve prolapse, so every couple of years I just go and check everything out. Saw a friend of mine there. Yeah, I had 3 stents put in about 4 months ago, and I'm just here checking things out. So this is just all day, every day. Had them at a meeting earlier in the day, and you guys just knock it out of the park. Boom. Dr. Munoz, how about you? How do you describe what you do all day, every day?
Yeah, I'm a cardiologist. I'm interventional cardiologist, so we do, like Dr. Cota, interventions in the heart or the legs. Basically, we can do some other places in the body, but mainly those. And we do also screening, take care of also the control of the risk factors for coronary artery disease and atherosclerosis.
So here's a question, and Dr. Munoz, I'm going to ask you because you brought it up. we talk about screening with so many, gosh, we talk about colonoscopy, we talk about getting breast cancer screening, we talk about prostate cancer screening, but I don't hear often screening for cardiologists or heart disease screening. I love that you brought that up because this show's all about prevention.
Right.
When do you know that you're a person that should be screened for something? It's so vague of a question. I get it.
Nobody.
But there are times it's like, my mom, my dad, my grandparents. So just answer that to the best of your ability, and then we'll expand on that.
Right. Actually, as you appropriately said at the beginning, cardiovascular disease is the leading cause of mortality in the United States and in Europe, in all the developed countries. So the way to prevent that mortality is prevent the conditions that cause those diseases: hypertension, high cholesterol, diabetes, tobacco abuse. Those are potential causes that we can modify. There are some that we cannot modify. We cannot modify our parents, unfortunately, for some people.
Right.
But all those other things we can really control. So anybody, that's why it's so ubiquitous, the coronary artery disease and atherosclerotic disease, that everybody needs to be screened. From now, the pediatricians start checking the kids for hypertension, for cholesterol, for diabetes, because it is now becoming a disease of younger ages.
And is that for just anyone who goes to a pediatric? I don't know. I guess I'm asking, would there have to be a risk factor first, or is this just something that we're just going to check?
Yeah,
all this
usually
out
what they check is, is the kid growing appropriately. But if they see that he's obese, that has family history, that he has some features that could be related to diabetes or high blood pressure, they check those.
Gotcha.
And so, but what I'm saying is that you start at a young age and you continue through your life. If you have family history of early coronary artery disease, if your brother had a heart attack when he was 42, then when you are really 18, 20, you got to make sure that your cholesterol is fine, your blood pressure is good, avoid smoking, and see what are the risk factors that your brother had or your dad had or your grandma that made her have a heart attack at a young age, and try to control that so you don't have it.
Nicely said. Dr. Ulasanya, I'm just going to have fun with you all night long. It is still Heart Month, so it's going to be like the language of love all night. Let's talk a little bit about warning signs. We talked about risk factors. And so the show goes, I know it's an hour long, but it goes by fast. So when we're thinking about just warning signs and symptoms of heart issues, not necessarily a heart attack, but just that things aren't going quite right. And again, the conversation I had with a gentleman at the doctor's office today, and I'll explain some of that too, but when patients come to see you, they're like, you know what, this has been going on, or if someone's referred to you, what are some of the symptoms that they tell you about?
Well, thank you for that interesting question. Well, the most common symptoms are usually exertional symptoms. So people notice that they get a chest pain or a chest pressure, or even just shortness of breath or lightheadedness when they exert themselves. And it typically creeps up on them. So you could be a person who could normally walk 10 blocks, 15 blocks, and now you notice after about 4 blocks, you get this chest tightness or shortness of breath. Those are very classic symptoms. However, in women, they tend to have non-typical symptoms. So they could have just shoulder discomfort that comes with exertion. It could be a pressure around their low upper belly. So whenever you have any of these symptoms that comes with exertion, don't think it's because you're getting older. It could actually be a problem with your heart, and you should tell your doctor and maybe get seen by a cardiologist.
I like that you say that, because sometimes I think we panic because we think, oh my gosh, it's something big, but sometimes it is, we're getting older, but the combination of the two is always a fantastic reason to go. Dr. Kota, let me ask you, and then afterwards, start thinking about taking this guy apart. But I'd like to ask you, Dr. Kota, about the most common, and again, let's stay away from heart attacks for a minute, because I feel like everybody talks about the heart attack, but what are the most common heart issues that you see in your practice?
I think the most common issues are the risk factors that lead somebody to develop heart disease. Because I think, like Dr. Munoz nicely said, it's all about a risk factor. These things creep up on you over time. So it's not like you have a cold and you get heart disease from one day
Right.
to the next. It's over years, and that's why if you control the risk factors, you control the onset of heart disease. So in clinic, we see a lot of people with uncontrolled blood pressure, a lot of people that have risk factors and they want to know how to weight loss, how to maybe stop smoking and decrease those
Okay.
factors. So when we see them in clinic, we try to do like a risk profile and see what's your risk of heart disease. Are you at very high risk? Are you at a lower risk? And how we can help you prevent heart disease moving forward.
Okay, nicely explained. Dr. Ulasanya, let's take this guy apart, because what I'd like to do for the audience at home is kind of go through the dissection of what the heart is, what does what,
Okay.
and what are we looking for as far as problems. I mean, there's like, if you could see this, there's like hooks and all kinds of cool stuff on this.
Let me see if I can get this up on the camera. So this is a,
I think it would be this one right here.
okay. Okay, this is a
Pardon?
rather large heart.
Oh,
but-
we're over here. Sorry,
We're
it's going
over
to be
here?
this camera. My
Okay.
apologies.
All right, so a rather large heart. Your heart is basically a very large muscle composed of 4 chambers, and the right-sided chambers and left-sided chambers. So I'm going to open this up to make it easy for those at home. So typically what these chambers do is the right side receives blood that has been has had all the oxygen taken out by your muscles, and this comes to the right ventricle, which pumps this to the lungs. It comes back into the left atrium, to the left ventricle, and is pumped into the body to provide oxygen to the muscles. Now, different issues occur with the heart. There could be primary issues with the muscle, where the muscles get weak and patients develop heart failure. There could be issues with the blood vessels. So if you look on top of the heart, there are blood vessels that run on top of the muscle, similar to veins that run on top of your fist. And these blood vessels are the ones that supply blood to the heart muscle. So when people have heart attacks, it's these blood vessels here on top that typically close off, and they get clogged by cholesterol plaques, and that's how most patients present with symptoms.
Interesting. So when we're looking at putting stents, for
Yes.
example, and I'm just going to, his name is Henry. There's no last name because there's a
Okay.
lot of Henrys in El Paso. He has 3 stents. Got them all at the same time. He said it was maybe a 20-minute procedure. What in the world does that mean to the people at home watching?
Okay,
Where would they be, and what would they do?
So I'm going to pass it to my interventional guys.
Okay,
They have
nice.
the best-
Okay,
Okay.
lovely.
I think this is a great question because
Yes.
you hear a lot about stents in you know the news and in people like you
Right.
run into your friends and family. So stents, essentially, if you think about a stent, it's like a chain link fence made into a circle, essentially, and it creates a scaffold to open up the artery and push all the blood clot or the plaque that has built up in the arteries over time to the side and let the flow go through.
Okay.
Usually stents, the procedures, when it first came out, we used to be going through the groin, through the right leg.
Yeah, I
and
remember
now
that.
I think about 90% of our procedures we can go through the wrist. It's easier access, decreased risk of bleeding. You recover way quicker. You know, it's a faster recovery. So we access usually through the wrist if your blood vessels are adaptable to that. Not
Interesting.
everybody
Okay, yeah.
is a candidate for that. I mean, you have to be above 5'2", and there's certain things we look into that, but most we go through the wrist.
Okay.
And we put essentially these long catheters, which is, if you think about it, just a long straw that gets us access into the arteries that
Okay.
we go into. And using wires and techniques, we deploy these stents that are kind of crushed over a balloon, and we go into the area where there's blockage or there's cholesterol buildup, and we
So
deploy
here's a
them.
crazy question from someone who doesn't do this. How do you see what you're doing, or how do you?
That's a good question.
Okay.
So to be able to look at the heart, we use live X-ray.
Okay.
So you can think about it like an X-ray when you get a X-ray at the doctor. That's just like a snapshot. That's like taking a picture. When we do these cases, we do it under live X-ray, which is a movie actually, and we use a medicine called IV contrast, the same medication that's used to get a CT scan or what have you.
Gotcha.
Just at a different concentration, and we inject it through these catheters and take a live movie. So we're actually seeing the blood vessels live and how they pump and how the blood flow goes through there. And with that, we are able to open up these arteries. So when people go through these procedures, you are exposed to radiation and you are exposed to contrast, but it's very minimal and it's very safe if it's only like a one-time thin, right? So when we do these cases, us as operators, we wear protective gear,
Right.
and we're limited on how much radiation, how much contrast, and all these things to keep the patient safe and be able to put stents in.
So here's a question, I said 20 minutes, that's what this gentleman said earlier today, but in general, he needed 3 stents. And I'm not exactly sure how to ask this question, but how common is it if you need 1, you're probably going to want 2 or 3 or need 2 or 3? And Dr. Munoz, I'm going to ask you in a minute how we diagnose some of these questions. But in general, when there's 1 stent being put in, and maybe there's another option or desire to, well, we should probably help out this guy at the same time.
Yeah, I think that's a good question. So in general, when we do a left heart cath, which is the procedure that this, or selective coronary angiogram, that's kind of the more formal name, it usually takes about 20 minutes to get access into the patient and take the pictures.
Okay.
20 minutes, nothing to be done. The patient can usually go home if everything goes well in about 2 hours.
Oh my
after
goodness
that
gracious,
post-op.
really? Not even stay overnight?
Exactly. And when we decide to put a stent, it all depends on the anatomy and the tests we have used to diagnose the patient, right?
Okay.
Now, by the guidelines of the American Heart Association and the American College of Cardiology, we have to make sure that the artery we're intervening actually needs it. So we
Right.
can do tests in the lab to document that. We really need to put a stent there that's really going to give you benefit, because people in the years past were kind of being a little bit using more objective data, subjective data instead of objective data, and now we're trying to really put stents where we really need them. And it all depends on how the anatomy looks when we take those movies. So if we
Gotcha.
put a stent, I think it takes us maybe an additional 30, maybe 20 minutes. So I did a case this week, and it took us about 40 minutes from start
Okay.
to finish. If it's a simple case, more complex cases can take up to 2-3 hours. And
Okay.
it all depends what equipment we're using, and the anatomy really kind of lets us know.
Okay.
when the procedure will
So
be.
I've changed my mind. Instead of asking about diagnosis, what I'd like to do, Dr. Munoz, is talk about once you have a stent, you always have the stent. However, let's look at 10 years down the line. Let's say it's someone who's 50. Relatively good shape, but now, this stent or 2 or 3 have been in there for about 10 years, más y menos. And is this a candidate that chances are in years later there might be another one? Do they go every year and get checked? Does, not necessarily a screening, but the checkup. So it's kind of like the diagnosis, but after the stents have already been put in.
Yeah. First, I'm going to say briefly like the stents, because now we're walking away from doing interventions when they are unnecessary.
Okay.
But one, when it's very necessary, is when you have a clot occluded an artery because of an acute heart attack. And that could
Right.
be maybe
Okay.
the only one when really is a class 1, when you really need a stent, because otherwise that area that artery was supplied of muscle will die. And then you may be left with congestive heart failure, so if you're having a strong chest pain or shortness of breath or nausea or something that you suspect that it's a heart attack, you need to go to the hospital. The stent is absolutely necessary. The rest of the stents, now the guidelines have changed based on the studies that really those stents don't prove to really improve mortality, stuff like that.
And so these studies, because I'm just thinking of how many years we've been doing this show, these studies have come out in the last couple of years,
No,
perhaps?
in the last 5-10 years,
Okay.
and along all this, intervention is relatively a young
Right.
science.
So to speak, yeah,
discipline.
you're right.
So, but we are learning. We've been learning. Stuff that we maybe did 20 years ago, now we don't do. We
Right.
do it different, etc. Now, once you have a stent, it implies you already have coronary artery disease. You may have coronary artery disease and you may not have a stent. You may not require a stent, but the treatment is the same. From there on, you require aggressive, more than the rest of the people, aggressive control of the risk factors that lead you to that stent in the past. So your cholesterol has to be really low. Your blood pressure has to be very controlled. Your blood sugar has to really be controlled. You cannot smoke. You have to start doing exercises. You need to eat healthy. You may never require another stent in your life. You may never. But if you don't control those things, you continue smoking, your blood pressure is high, your cholesterol is high, very likely you're going to require
Exactly.
more stuff in the future. And a stent may not be enough in few years. You may need coronary artery bypass graft surgery because all your major arteries have blockages.
Right.
So it depends on how you really control yourself.
Yes, go ahead, Dr. Cota.
I think Dr. Munoz brings up a good point. If we take 100 patients with an acute heart attack or somebody that requires, about 80% of the time we can fix it in the lab with stents. There's the 20% that need bypass surgery, and it all depends on the extensiveness of the coronary artery disease when we do the left heart caths to define there. And I think with time, we're moving away from permanent stents.
Right.
There's a lot of data coming up with these bioabsorbable stents. They came out recently.
Yes, I read a little bit about that.
They came up recently with one in the past for many reasons that are, that are more complex. It didn't work out, but I think in the next 5 or 10 years, we'll be moving away from the metal stents into more these bioabsorbable stents, and that's good for many reasons.
And that's fascinating. I have to stop for just a second. We have a ton of questions coming in from the audience, but I do want to say and let everybody know that we are also streaming on Facebook Live, and on Facebook Live, you can actually ask your questions there as well. So we've got someone here technically doing that and talk about, that's not something we did even 2 years ago. So everything's new and everything's going forward. So again, Facebook, just find PBS, KCOS, PBS in El Paso, and you'll find the El Paso physician on there. Again, we're getting questions like crazy from the audience. So I'm going to just start throwing these out because time goes faster than you think. So there's a question here from the audience. Actually, we didn't go into diagnose really. So I'm going to ask you a little bit about how you diagnose certain issues. So we talked a little bit about people coming in, fatigue, they've got symptoms. What tests do you run? And that will help with some of these questions that I have here.
Thank you for that question. So the most common test that we run is plain exercise stress test. The first thing we always do is an EKG, which is an electrocardiogram. And this displays the electrical activity in the heart. It could tell us if a person has had a heart attack before. It can tell us if a person is having a heart attack now. And what we try to do is we put this person on a treadmill. There's a protocol that's standardized around the world. And we slowly, incrementally increase the workload on the heart while an EKG is ongoing. And if there are truly blockages in the heart, the EKG shows us specific changes that let us know that there's something to be done. Now, we don't do that same test for everybody. It depends on what you think your probability of the disease is before the test. So if you have a 60-year-old man with high blood pressure, diabetes, and hypertension, they may end up needing a nuclear stress test, while a 22-year-old with no other medical problems, a simple treadmill stress test, which we can do in the office, should suffice.
Nicely answered. You were talking about electrical pulses to the EKG, and I've got a couple of questions here, some on palpitations, other one on arrhythmias. So, Dr. Cota or Dr. Munoz, who would like to talk about your heart beating in a funny way? Here, Dr. Cota, you're smiling and nodding, and Dr. Munoz, feel free to add in. And that's, we hear about it all the time now. It seems like every other commercial you see is some medication, but talk about what the causes are.
Yeah, it's a broad topic when people say palpitations, and in the general population, they're extremely common. They're very, very common.
Thank God, because I've got them all over the place.
At many ages, even from young to old. And the people you usually see in clinic are the ones that have symptoms, meaning they feel them. They feel the palpitations. And one good way we evaluate that is a little, what we call a Holter monitor.
Okay.
It's a little patch that you wear on the skin you can do it for 24 hours, 72 hours, you can do it for 21 days. And it lets us know that rhythm of the heart to see if there's any extra beats. And like with anything, there's extra beats that are very benign, very simple, not leading to anything more severe. And there's other extra beats that could be a sign of the heart not being happy, an artery not being happy, and what have you. So these monitors monitor you 24/7 and let us know where these beats are coming from. Usually, in general, the beats that come from the top, if you skip 1 beat, 2 beats, it's relatively within the realm of norm. You should still seek your doctor's advice. But the palpitations that really concern us are the ones that last for 5-10 minutes. You get chest pain, you have trouble breathing, you're feeling dizzy, or that come very frequent. Because a lot of things can give you palpitation: coffee, chocolate, tea, and all these things that can lead to them.
Right. So, Dr. Munoz, I'm going to ask you kind of on that same line, and what I like doing with the audience is giving my example. If you've had heart issues or you have, by all means, let them know. So, I have palpitations, but I also felt like my heart was going to beat out of my chest, and it's something I've had for years and years and years. So, 3 years ago, I did wear a heart monitor for 21 days, and I do have extra beats all over the place. I mean, it's just, but they're benign. So it's chronic, but thankfully in me, benign. So it's just one of those situations where you watch it and you just see what's going on. Thankfully, I've never had any pain. I've never had any shortness of breath or anything associated with that. So on that note, Dr. Munoz, let's talk about those that are now not benign.
Right.
And we can talk a little bit about ablation. I know there's a whole show in and of itself with ablation, but I'd like to touch base on that because when we're talking about electricity in the heart, that's fascinating in and of itself.
Like Dr. Olusanya said, the heart is a big muscle, and that beats without us thinking on it. So it has an electrical system that is automatic. So arrhythmias, that's the way we describe when the rhythm is normal, we call it sinus, is normal, 60 to 100 times per minute. When it is abnormal, either too fast or too slow, is an arrhythmia. Now, the arrhythmias that we consider not so benign, they are of several types. They can come from the top of the heart, or they can come from the bottom. When the heart is very weak, in people with congestive heart failure, with low, we call it ejection fraction, the ventricle is not able to squeeze good amount of blood, there is an arrhythmia that is peculiarly risky. Ventricular tachycardia, ventricular fibrillation, you see the people that can die of that arrhythmia. You need to defibrillate that person out of there, otherwise he's gonna die. And some other ones that we care a lot, and lately we have been paying close attention, is atrial fibrillation. Because can lead you to strokes, which are very disabling. So when...
And I'm going to stop you for just seconds. I want to make sure the audience understands. You're talking about the bottom of the heart, the top of the heart. Just go over that again really quick, why it matters if it's the bottom of the heart or the top of the heart.
Yeah, usually those ones that I'm talking at the bottom of the heart, like Dr. Cota was saying, they can go from something that is totally benign, like extrasystoles, PVCs, to something that is very malignant, a ventricular fibrillation, ventricular tachycardia. If you are even at risk of developing those arrhythmias, we put a defibrillator. The electrophysiologist or a doctor, that a cardiologist that is trained on that, put a defibrillator, because if you have that arrhythmia, you may not make it. So even if you are at high risk for developing the arrhythmia, but you never had it, you need a defibrillator.
Which is basically a pacemaker, correct?
Which is a bigger pacemaker that can deliver a shock to your heart if you have the arrhythmia.
Okay, so explain what that is then. So if you have a defibrillator, it is something that only goes into play when it's needed, when the body says something's up?
Yeah, the defibrillator can work as a pacemaker too. So if you need it as a pacemaker because your heart is slow, it does that function. But mainly it's there if your ventricle, the bottom of your heart is going to have one of those malignant arrhythmias that is going to kill you.
Gotcha.
Yeah, that's the defibrillator. Now, the arrhythmias of the top, they can be also benign. They can be extrasystoles, that we call it PACs. They are very benign. Or they can be atrial fibrillation, that we care a lot, atrial flutter that behaves like atrial fibrillation, or supraventricular tachycardia that is like what you had, Catherine, like the heart trying to get out of your chest 150, 170 times per minute.
It's a little freaky when it happens, I gotta say.
It's likely a supraventricular tachycardia, common in people with mitral valve prolapse. That's relatively benign and can be ablated.
Good to know.
Any one of those rhythms have indications sometimes for ablation. Go there, and because it's an increase of automaticity on that electrical system, so you can go with a catheter and burn the little area that is causing that arrhythmia. Not in everybody that has the arrhythmia, but many people benefit from
pardon my ignorance, if you're going in for an ablation, what are you taking away? Is it an electrical, I know it's a little electrical charged in one specific place. How is that done?
You have to go and map and see. You localize the area where that short circuit is. With several catheters and mapping. There is a special mapping that you can do.
So you just find out what's causing that extra heartbeat in there.
And burn it. Now, for atrial fibrillation, there are special techniques. You isolate the pulmonary veins. I mean, some peculiarities that maybe are not that important right now. But the important thing is that all those arrhythmias can be treated.
Gotcha. Question here from the audience. This is causing me anxiety, and that's what this question's all about. No, the question is, can anxiety or stress cause arrhythmia? You were talking earlier about coffee, sometimes caffeine, et cetera, et cetera. So There's another question here, can anger cause heart trouble? So let's just take this question to the, you guys, all three of you laughed at that one. You're mad at somebody today, right? So Olasanya, let's talk about stress, emotions, feelings, just and what that does physiologically to the heart.
So, I mean, people who are in a chronically stressed state, they release a lot of adrenaline constantly. This can keep your blood pressure elevated and contribute to heart disease. But in some people, that's the first time they ever find out that they might have a problem with their heart. Because remember I told you initially that most of my patients come in because they have exertional symptoms.
Right.
Well, there's physiological stress, which is you walking up a flight of stairs, and there's emotional stress, which is you getting very mad. And sometimes in that anger, I've had a couple of patients where that was the first time they ever knew that they had heart problems, because the anger, it's usually a spouse, usually the husband.
Right.
Oh,
you're good. You're good.
The wives come in with chest pain after they've had an argument, and we found out that they had heart disease. So it can cause it, and it can also be a way where you find out that you actually have a problem with your heart.
Okay, so here's the $10 million question. How does one treat, without getting a divorce, how does one treat that type of stress to the heart versus the physical stress of having to run around, et cetera, et cetera? Is that something where, and I say this and it's loaded, because I know there's anxiety medications, there's depression medications, and we haven't even gotten into the whole myriad of cardiac medications that are out there. And so between all three of you, if anybody wants to take it, how does one treat stress-related heart issues? We can look at diagnosis too. It's a loaded question, but maybe just throw out some. Dr. Cota, you're smiling and nodding. If you smile and nod on the show, it's your question. Just letting you know.
I think it's an interesting question, but I think with anything, right? We recommend our patients to exercise and have a healthy lifestyle.
And
that's not only physical but emotional too, right? I think exercise not only brings physical well-being but also emotional well-being. You know, people tend to sleep better. They release the stress when they exercise, and that can help as well. And I think also, you know, if there's a situation that angers you, you know, talk it out with the person, because yes, it can affect your heart, like Dr. Olasanya said. There is that emotional stress, and like you take care of not smoking or, you know, controlling your blood pressure, you also need to control anger and that situations that bring you that emotion.
You're nodding, so I know you have something to add. Olasanya?
I mean, a lot of times I just tell the patients, you know, you have to take it easy. Like Coach has said, some people have asked me for prescriptions to have their husbands not disturb them.
Right.
But I just can't medically write that for now. But
so I'm going to tell a joke. Today is actually my 52nd birthday, and somebody delivered a bottle of wine to my office. And they said, well, I know that you have the cardiology show tonight. And usually the cardiologist will say, have a glass of red wine. Calm yourself down, it's good for the heart. And I almost brought it tonight, and I thought, I can't do that on a medical show, but I almost did. But it kind of goes into what you're talking about. Just treat yourself well. Dr. Munoz, I'm going to throw this your way because you are the veteran on the show. Let's talk about what different medications do physiologically for cardiology, because there's beta blockers, there's just all kinds of stuff out there. Statins are out there, and that's and it is a mixed bowl. It's a bunch of jelly beans running around. So I just want you to start the conversation. And I don't really have a question, but I know that we've got several questions in here about medication, so I'm just going to have you start.
Yeah, the spectrum of medications that we use now in cardiology is huge. It's growing. Every year we get new medications, and we get some through the years that are really critical to treat patients with heart disease. Antihypertensives are maybe the ones that we use the most, and they can treat hypertension, but they can treat some other things, like you mentioned beta blockers. Beta blockers are essential in people that has coronary artery disease because they decrease the risk of dying of heart disease.
Right.
Not only lower the blood pressure, they can prevent arrhythmias. There are several other antihypertensives, ACE inhibitors like lisinopril, or ARBs like losartan, and all the combinations. Now, statins are also very critical in our practice because we have known through the studies through the years that the lower your cholesterol is, the lower your chance of having coronary artery disease. So they are very critical. And not only statins. Now we have some other kinds of medications that we can use also subcutaneous to decrease the blood pressure, and many other in the same line. Antiarrhythmics. When you have an arrhythmia, you may take a medication to prevent the arrhythmia from happening. Usually those medications don't decrease mortality. They make you feel better. They prevent the arrhythmia, but they don't decrease your chance of dying. So when somebody goes to my office and has a cardiac condition, or the office or any one of us, the first thing that we said is which medication, if this patient needs any, is going to decrease his chance of dying.
Exactly.
And
so
that
it's
one,
the end game. It's all
and that
about
one
the end
goes
game.
first.
Okay.
That one goes first, and I say never stop that thing unless the science in 10 years tell me something different. So those are the first medications that we use. Sometimes they can be one, but somebody has a heart attack, left the hospital, he's going to need maybe 4 or 5 that accomplish that. And they say, you're going to put me on 4. I wasn't taking anything. But I say, but your chance of dying decreases with every single one of those.
Right.
So it's very important. So the first ones, the ones that allow you to live longer. Second ones, the ones that treat your symptoms, that you're going to feel better because you're using that. But the spectrum of medications is humongous right now.
It's crazy, I can
Yes.
imagine. Dr. Cota, you were talking earlier too about, and I do want to stress lifestyle. So there are medications, and that's great. There are getting your wife and you're getting your husband to be nice to you, that's a whole nother thing. We're talking about taking a walk. We're talking about eating right, etc. So I'm going to have you be that commercial right now of what you need to do in your lifestyle that you can do without necessarily always going for the medications.
Sure, and I think Dr. Olasania said a very good point. You have to remember your heart's a muscle. So with any muscle, bodybuilders always do weights to get their muscle bigger and stronger and more efficient. Lifestyle changes do that to your heart inadvertently, right? Walking at least 30 minutes a day, 4 times per week, starting slow. You're not training for a marathon. Just go out and walk. Just walking does well. Stationary bikes. Those kind of healthy lifestyles get you into a habit. And I get a lot of questions from patients. What's my diet? What should I eat as a diet? And I'm just going to talk in general, not specific to diabetics, but just in general. I always tell people, don't live at the extremes. Don't eat meat every day. Don't not eat meat, right? Meat once per week. Fish and chicken the other days. Try to stay away from fried foods. Try to stay away from fast food. Anything that's preserved, like cans or frozen food, has a lot of salt in it to preserve it, to keep it in the shelves for a long time, and those can increase your blood pressure. So I always tell people, if you're going to eat vegetables, try to get them fresh.
Right.
There's also a lot of talk about carbohydrates, right? The Atkins diets and all these things. Your body needs a certain level of carbohydrates.
Thank you.
And like I tell patients,
you need a little bit of pasta and a little bit of bread.
If you go to Chili's or Apple, these huge plates.
Yeah, proportions.
Proportions.
My gosh,
so
yes.
I always tell patients by rule of thumb, and if you go out to eat dinner, eat 70% of the plate. Eat a little 30%, and that's fine. The portion control.
Split
Or
the plate. It's good for the pocketbook too. Yeah.
Exactly.
Agreed. Nicely said. You were talking about strengthening the heart muscle, and Dr. See, I messed it up again. Olasania. See? The question here, and this is from the audience, how does one strengthen the heart muscles to prevent them from weakening? So if it's what we were talking about, just using them, if that's the right question, I have a follow-up question from there. When we're looking at, I guess just regular exercise, but I feel like there's something more that you can do with heart muscles. Is it just simple exercising? But then there's that question of, do you do the sprints, or do you just get out and walk for 30 minutes? And I'm hearing like the walk for 30 minutes.
Mostly the walks.
Okay.
The walks are good as long as you keep yourself. The American College of Cardiology just says you need to keep yourself active. So 30 minutes a day of some aerobic exercise. It could be just walking around your park, walking on a treadmill, and just do that 3 times a week or 4 times a week if you can. And that just keeps your heart strong.
And park far away. You don't need that first space.
Exactly.
Yes, Dr. Cota?
Because a lot of patients tell me, well, I do a lot of stuff at home. I clean my home.
Yeah.
And
doesn't
that's not
count.
true exercise. You want to keep your heart rate sustained above a certain level for those 30 minutes.
That's what I'm looking for. Okay.
You have to so that's why we say walk, stationary bikes. Do something that keeps you. Swimming's also a great avenue, great exercise, and it's to keep your heart rate elevated for those 30 minutes.
Nicely said. Question here from the audience. What preventative steps can someone with atherosclerosis, I'm saying that wrong, atherosclerosis, take to prevent further cardiac complications? So preventative steps. I know we're kind of talking about that right now anyway, but.
Yeah, exactly. So that's a very good question. So anybody with atherosclerosis, which means just technically cholesterol plaques lining around your arteries, and that's the same process that causes heart attacks, the same process that causes strokes, and the same process that causes peripheral artery disease. It's all about aggressive risk factor modification, like Dr. Munoz and like Dr. Kota have stated. If you're diabetic, you have to get your diabetes under very strict control. If you have high cholesterol, you have to be on statins, you have to watch your diet. If you are hypertensive, you have to control your high blood pressure, whether it's by controlling your stress or being on medications. Exercise, it's this combined effort that attacks all those risk factors on all fronts, and it will prevent the atherosclerotic disease from getting worse over time.
Here is, and I'm going to give it to you because you were just answering that question here from the audience. It can go to all three of you as well, but can you clean the veins? And this specifically says after a DVT. Again, it's a cold question from the audience. If anybody wants to take it, you're smiling and nodding. Dr. Kota?
Okay, so
Dr. Kota, so can you clean the veins after a DVT? Is there such a technique? And if so, does one exist in El Paso? Question
yes,
from the audience.
that's a good question. I think we're moving away from the arteries into the veins. The arteries take the blood to the rest of the body with oxygen. The veins return the blood back. And it's a very common condition to have a DVT. That just means a deep vein thrombosis. That means you have a blood clot in one of your veins. There's several risk factors like inactivity, a long road trip or what have you. But to answer the question, they're saying usually when they have a DVT, there's several techniques we use, and one technique is blood thinners. The blood thinners will help prevent the DVT from getting bigger, and the body eats it away. If it's a very extensive DVT, there's a procedure we use and a special catheter we use. It's called ECOS, and it's a pretty cool technology. It actually, with ultrasound waves plus depositing a very strong thrombolysis, which is a medication that breaks up the clots, and we put the catheter. We usually keep it about 24 hours sometimes.
Interesting, yeah.
And you can dissolve the blood clots in the legs.
Really?
We rarely use it for the legs. We use it more when that blood clot reaches the lung, which is called the pulmonary embolism, which can be very fatal and can put a patient in a lot of.
So this is specifically for a clot?
Yes.
Okay, and and my apologies because I'm trying to follow. Is it something that's also put in there to help dissolve the clot? Is it a mechanical thing, or is it a medical, or is it like a medicine?
Yeah, it's a combination of both. So depending on how big the clot that reached the lung is causing the patient distress, their oxygen levels are very low, their heart rate's very high, their blood pressure is low. We go in through the groin, through the vein, and put this catheter that with ultrasound and depositing this medication continuously for 24 hours will dissolve the clot.
So how does one find where the clot is? I mean, if the symptoms are in that area, I get that and I understand that. But if you're searching for a clot, is that even a thing? Where you're like, let's check out the entire body and see if you have a clot somewhere?
Yeah, usually when somebody comes to the office and they're having just one-sided leg swelling, we're concerned, and with an ultrasound, which is a very non-invasive technique, we can see blood clots in the legs. But if a patient comes up with further symptoms and we think the blood clot reached the lung, we have to do a CT scan usually, or we can do another technique, and that's a little bit less invasive, called the VQ scan. So there are these two techniques to help us identify if there's a blood clot in the lung.
Okay, very nice. We are at about the 13-minute mark, so I'm going to stop. I have plenty of questions here from the audience, but I'm going to stop for a couple of minutes. And Dr. Munoz, I'm going to start with you, again, because you're the veteran, so you get to be the leader. There's so much with cardiology. There's just so much. Is there something that we haven't talked about tonight yet that you'd like to talk about? Because again, you've done a lot of these, and I feel like you've always got information to throw out there.
Yeah, we're talking about parts, and so I want to go to a couple of things in the heart. One is congestive heart failure.
Yes.
And like when somebody was asking, what can I do if my muscle is weak? So if the person is referring to weakness, like the left ventricle is not able to pump more than 50%, more than half of the blood that receives in every diastole, if you cannot pump half in every systole, that means congestive heart failure, of one of the types of congestive heart failure. So if you have blocked coronary arteries that are providing flow to that muscle, that's the first thing. Get blood there. Sometimes you need bypasses.
Right.
Stents can do it to certain extent, extent, and medications. There are some medications that are proven to increase the strength of the heart.
And you know,
So
we didn't
congestive
talk
heart
much about bypasses at all. So take a couple of seconds and talk a little bit about what a bypass is.
Yeah, a bypass is a surgery that provides flow to an area that is blocked. You have a blocked coronary artery, and then
Do you want this guy?
Yeah, we could. Yeah.
All right. He's heavy, so.
Yeah. So you have here the coronary arteries that are in the surface of the heart. So you can either go inside and put a stent if there is a block, but if you have a block everywhere in the three major coronary arteries, especially in the one artery that we call the left main or the left anterior descending coronary artery, and the person is diabetic and the muscle is weak, the best thing is to do bypasses.
Right.
So one bypass that lasts very long time is what we call the lima. So in the subclavian artery, there is an artery that leads to the left side of the chest that we call the left internal mammary artery. The surgeon gets that artery and bypass it and put him past the blockage in the coronary artery, and can get veins from your legs and bypass the blood from the aorta past the block of the coronary artery. Those are the coronary artery bypass graft surgery. Many times, along with those surgeries, we need to fix valves.
Right,
That's another complete different subject, but I don't want to go over 20 things.
Yeah, but that makes sense.
Yeah, but so that's what a bypass is. You know.
And a bypass lasts a lifetime, depending on when a person
Yeah,
has it?
the average duration of the veins is 7 to 10 years. The lima, the left internal mammary
Right.
artery, the first one, may last 20. I have seen people with 35 when they invented that surgery, like 35 years ago, 38, and it's still open.
Wow.
So that's what we insist very much on the
Somebody needs
surgeons
to give
getting
that
that.
doctor a medal. That's impressive.
I know.
Seriously,
yeah.
no, that's fantastic.
Yeah.
Okay, so Dr. Cota, anything, actually, Dr. Munoz, is there anything else you want to talk about? I'm glad that we got to bypasses, and that was my fault, because I
quickly,
asked you
2
about
minutes,
that. Yes.
because
Yeah.
I want my
we
partners
have time, that's why
No,
we
I want my
stopped, so we're
partners to
good.
talk.
Yeah.
The peripheral vascular disease. The same blocks that can happen here in the heart can happen in the arteries or your legs. You can lose the limb if those blockages are severe. We treat those too, either with medications, or sometimes we have to go and dig and open those arteries too. So, I mean, briefly.
We need to dig and open those arteries too. I love it because it creates a visual and it helps out. Dr. Cota, since you have not been here before, now what would you like to say that we may not have touched base on, or would you like to reiterate?
No, I think the biggest thing to reiterate is if you have symptoms and you're concerned, seek medical attention. It could be the first signs, and it could be life-saving. And I think also what we call compliance with medications. I think it's a big topic here in this region where a lot of people say, I don't want to be on medications, why am I on these medications? But like Dr. Munoz and Dr. Olasani said, they can be life-saving. And we try to use the minimum amount, but some are needed, and they do extend your life. We see it every day. Some patients might not think or see it on a daily basis, but I think those are kind of my takeaway home points from
So that
this
stuff
talk.
matters.
Yes.
Absolutely. You, sir, doctor with the cool name, or lasagna?
Yeah, that's close.
You'll get
very
there. It's because we haven't had the glass of wine yet. I'm waiting.
So I'm more of a non-invasive cardiologist, so I believe in prevention. So it's the same things we've said. First, making sure that if your risk profile is high, or if you don't even know what your risk profile is, you can see your family doctor and ask, what is my risk profile? I'm a 50-year-old female. My dad had a heart attack when he was 45. I've smoked before. There are risk scores that we can put this together and say, well, your risk for a heart attack is 7% over the next 10 years, so maybe you need to be on such and such. So just preventing, because we have a plethora of medications and even just lifestyle modifications that can prevent you from getting to the point where you need Dr. Cota and Dr. Munoz.
Right,
you don't
right.
to need them.
Right.
Sorry. So you want to prevent disease as much as possible. So that's my angle mostly.
Okay. Yes,
Just
Dr.
to add
Cota?
one more point, I think nationwide, the number of acute heart attacks, meaning that you're rushed to the lab, or even heart disease, has been on a decline. And I think that goes
nice.
in terms to medications, the new medications that are out there, including statins, lifestyle. I think people are more aware of their health. So I think we're moving in the right direction for heart disease.
Beautifully said. I do think, I agree with you, I think people are more aware of their health. And I think sometimes, it sounds crazy, but social media, even though people are stuck on their phones all the time, but they get a lot more information than they used to. And I think that's helpful too. I do want to talk about when someone has an acute issue. Let's talk about calling the ambulance, calling 911 before, well, maybe I'll make it to the hospital, or Mija, can you drive me? Let's talk about that, because I think that's so important, the window of time. And I'm throwing that out to whoever wants it.
Sure. I'm going to let him go because you're
okay,
interventional.
and then Dr. Munoz, I want you to add to that.
We'd rather see patients in the hospital and nothing is wrong with them than just have a few that come in very severe. So if you have chest pain, trouble breathing, you feel off, call 911 immediately. There's a timing issue.
Right.
If you're having an acute heart attack, you do way, way better if you present to the hospital within the 4-hour time of onset, because we can open up the artery immediately. Time is muscle. So the more time that artery is clogged, the worse outcomes for you and the more risk of your heart function being taking a hit, being depressed. So if you come in within the first 4 hours, it's the best time for us to.
And the blood is the oxygen, right?
Yeah,
I mean,
exactly.
that's the
Once
big
you
thing.
get to 24 hours after the onset of the symptoms, you know, there's still a chance to help you out, but you do worse than if you come in within the first 4 hours.
Okay. Dr. Munoz, anything to add to that?
Yeah, we have to also see all the cardiovascular system. So a stroke is very important, and it's part of the arteries that go to the brain. If you have one of those arteries burst because your blood pressure is very high, or you have a clot that came in from the heart, or a plaque of cholesterol that ruptured inside one of your brain arteries, you're going to have a stroke that is very, very disabling. The same risk factors that we have for coronary artery disease are the same risk factors that you have for a stroke. So if you control those risk factors, you are also preventing a stroke. If you have neurological symptoms, if you cannot move one side, if you have a horrible headache, if you are not able to talk, you need to go, and usually the window is even shorter than from heart attacks. The muscle of the heart is more forgiving. The brain is not. Once you occlude one of those arteries, you need to open it immediately. And we have centers here in all the hospitals that can treat those conditions.
Okay, I know we've kind of talked about this, but let's quickly see if we can separate heart attack symptoms from stroke symptoms, and I'm throwing that to you. Bottom line is you got to call 911 anyway.
Of course. So a stroke, in simple terms, is a focal neurological deficit, which means one part of your body, either your face or the skin on one side of your body, isn't responding anymore. So you have weakness in your hand, a droopy face, or clumsy hand. That's a stroke. A heart attack is the same thing, but it's a blockage to the artery in the heart itself.
And what are you feeling?
So you're going to feel chest pain.
Okay.
You might feel nausea. Some people feel burning. Sometimes it's not even chest pain. It's just a chest discomfort that's sometimes going down your arm, radiating to your back, with shortness of breath, nausea, vomiting. If you feel any of those, you have to call 911. Do not drive by yourself.
Right.
And the reason why we state that you shouldn't drive is part of the complications is you could go into that ventricular arrhythmia that Dr. Munoz talked about, and you could lose consciousness. We've had patients who tried to drive themselves, but unfortunately, they went into VTAC or VFib, and they just died on the road. So,
and the beauty about an ambulance, it's equipped.
Exactly.
And they
can shock
call
you out of
ahead and
it or
say,
do whatever they need to do.
This guy's got this and this going on, so it's worth it. Call the ambulance. I so believe in that. We've got like a funny time frame now. We've got about 3 minutes. So I want to say thank you. Thank you so much. Las Palmas del Sol Healthcare, who sponsors this program tonight specifically. And I also want to say thank you to the Paul L. Foster School of Medicine, to the students. Are you guys back there? Hi. We have Aaron here today, and we also have Bobby Garcia, and he's got a name tag on and everything. At first I said, hey, what's your name? He said, Bobby. And I said, what do you like better? I like Bobby better. And he looks like a Bobby. So thank you so much for taking down these questions. We appreciate it. And if you missed a couple of things on this show tonight, there are several places that you can view this program again, and that is at kcostv.org. You would look under TV schedule, local programs, and just find the El Paso Physician. And you can also find this on the El Paso County Medical Society website at epcms.com. And they have this show posted. Just find, again, the El Paso Physician's logo on there. I am going to ask one other question, because we do have an extra minute that I didn't know we had. Enlarged heart. My primary doctor said I have an enlarged heart, but it's chronic but somewhat benign. We didn't talk about that at all, and I'm waiting for time schedules, but is there anything that we need to concern ourselves about? And I've heard of enlarged hearts in brand new babies. Is that something that causes symptoms and problems throughout one's lifetime? Again, it's a question from the audience. I wanted to honor it. Look, everybody's looking at you. I love it. It's like, I don't want to. And we cannot answer that question and totally go to a next one. Okay. Okay.
So, and it depends on why the heart is enlarged. So when people tell you you have an enlarged heart, it's usually from an X-ray where the heart looks like it's more than 50% of the thoracic cavity on an X-ray.
Gosh, that's
and the heart could be enlarged. It could be any of these chambers. So the first thing to do if your heart is enlarged is to get a sonogram, an echocardiogram, where we take pictures and look at all the chambers to decide in this particular patient which of the chambers is causing the entire heart to be enlarged.
Okay.
And then the management depends on what's causing the enlarged heart itself. So it's not just one thing, it just means as a whole the heart is big.
To be conscientious of it and check it out and make sure everything's groovy on that. Yes. Question here from the audience, Dr. Cotto. We talked about stuff that can cause palpitations. So can certain medications cause heart palpitations?
Yes.
Yes. And caffeine, you want to go through some of that really quick?
Yes, some of the medications that are known to cause palpitations or some of the psychiatric medications can do it. You know, so even some of the medications we use can cause palpitations. Caffeine, very known to cause palpitations. Tea, chocolate for certain people do it. Energy drinks.
Okay. Oh man. Drinks. Oh, I am not a fan of energy.
Yeah. A lot of asthma treatments too. Yeah. People who are on albuterol, they cause a lot of.
I remember Sonny Boy who had issues when he was young. He would be running around the house. So we've got about 30 seconds left. So again, I want to say thank you very much, Dr. Beños, Dr. Olusanya.
Oh, that's good. Perfect.
See,
you finally got it.
I actually read the way it was really spelled versus the way I had it spelled with myself phonetically. So, and Dr. Cotto, I hope that you've enjoyed yourselves. I always enjoy this show because I feel like with cardiology, everyone has a question, and we noticed that this evening. And so we have so many more that I'm just going to give to you because it's kind of fun to watch this. Yes. You can, again, rewatch this on Facebook tonight if you are interested in doing that. Thanks for watching the El Paso Physician. I'm Catherine Berg, and we bid you a good night.